Good evening, everyone. So, at the outset, I'd like to thank the organizers for this opportunity. And I think the Year in Review has become one of those conferences that we all await to collate a lot of the data that was presented the year before. So, I'm going to try and do justice to the abstracts assigned to me on the rapid review. And I've tried to group them together by similarity. The first of which was from the Swedish group on survival after BCT versus mastectomy, adjusting for comorbidities and socioeconomic status. You'll remember that a couple of years ago, the Swedish group had put out data saying that the BCT in a prospective cohort or a prospective analysis of a retrospective cohort, there was better survival in the breast conserving group, specifically for the lower size tumors or the T1N0s. So when they looked their data again, trying to adjust for pivotal confounders like comorbidity and socioeconomic status, this is the data that they published in JAMA 2021. Little over almost about 49,000 patients, 59% of which had had a BCS, 25% mastectomy without radiation, 14% mastectomy with radiation. At a median follow-up of about 6.5 years, the mastectomy group, though, had older patients, lower level of education, lower income, and probably more comorbidities. When they adjusted for the covariates, the overall survival and breast cancer specific survival was significantly worse in both mastectomy groups with and without radiation. And when you look at it in the T1N2s or the T2N2s, the blue graph, which is the mastectomy with radiation, have done worse. That is that someone with a heavier burden of disease has actually done worse with time, and a lot of it is just going to be biology related. So despite adjustments for previously mentioned confounders, we found that BCS yields better survival than mastectomy in this group of patients, irrespective of the presence of radiation. So what they concluded was that if both interventions are oncological options, mastectomy should not be regarded as equal. I would think that this is just evidence for safety of BCT, which has been taken to a slightly different level and shown us that, yes, there is more evidence for safety of breast conservation. Why is this relevant in a situation like ours? Despite all this emerging evidence on safety of BCT, especially in the early breast cancers, the rate of BCT in India is still about 40%. We'd conducted a survey to understand knowledge, attitude, and practice of surgeons offering breast surgeries and found that those who did not offer BCT to their patients quoted reasons of patient compliance, fear of recurrence, or inadequate training of breast surgery. Two of the physician-related factors that stood out was inadequate surgical training and lower volume of cases. And I think what we need to take away from this abstract is there needs to be better awareness among the physicians itself to understand the safety of breast-conserving surgery, especially in early breast cancers, and offer that to our patients. The second abstract talked about axillary pathological complete response and just the rates of that by different subtypes post-NACT. So this was a systematic review of 33 studies, 5,700 odd patients, and suggested that the axillary PCR rate was highest in the HER2 positive group and, of course, highest hormone receptor negative group. As expected, the luminal had the lowest of about 13%. Surprisingly, there was no difference whether the patients were node positive or node negative to start with pre-neoadjuvant chemotherapy. And they also said that the correlation between axillary PCR and survival in these certain subtypes is still not very clear. A similar analysis done in 2017 in JAMA Oncology had also told us that HER2 positive subgroups had the highest rates of nodal PCR. Now, how this helps us is that we've moved towards an era of axillary conservation, including in a group post-neoadjuvant chemotherapy. So when you're picking patients whom you'd want to give neoadjuvant chemotherapy to be able to offer less extensive axillary treatments also, a HER2 positive group may be someone that you tend towards, primarily because you expect to get more nodal PCR in that group. And I think that's what we take away from this data. The next abstract was about lymphedema rates, and we've known of our traditional concepts of lymphedema to say that factors that increase the incidence or are associated with an increased incidence would be BMI, type of surgery, nodal yield, type of or extent of axillary dissection. So this paper tried to understand race and ethnicity on the incidence and severity of lymphedema in a group of patients undergoing ALND and also identify risk factors with it. In that cohort of about 304 patients, 276 had at least one measurement, which was longitudinal from baseline. Among the Blacks and the Hispanics, they found that there was higher BMI and axillary RT rates among the Blacks and Hispanics, though the MRM and nodal yield rates were similar across all ethnicities. At a median follow-up of about 22.6 months, 56 out of those 276 had developed lymphedema. And as expected, we saw higher rates of lymphedema among the Blacks and the Hispanics. But what's interesting on the multivariate analysis, it wasn't just ethnicity and race, but also neoadjuvant chemotherapy, time from surgery, and increasing age that stood out as risk factors. The traditional known, the BMI, lymph nodes removed, or type of breast surgery somehow did not seem to stand as significant anymore. What they concluded was that there is a higher incidence among specific ethnicities after adjusting for other variables, and neoadjuvant chemotherapy increases this risk of lymphedema. Now, that mechanism of action is not very clear, but it's postulated to be related to fibrosis of tumor-filled lymphatics and endothelial damage prior to surgery by neoadjuvant chemotherapy. So I think what we then need to look at is that groups which do not necessarily achieve nodal PCR, which we saw in the previous abstract, like the luminals, probably need alternatives to neoadjuvant chemotherapy if you're going to have to do an ALND later anyway. So I think that's also another way of looking at both abstracts together, is understand what are the various risks your patient's going to have related to morbidity and what treatments we can alter or sequence differently so as to be able to give them more appropriate treatment. This, I think, was one of the most interesting papers, which was an abstract from ASCO 2021. It identified a novel biosignature to look at patients who had unacceptably high rates of local recurrence after BCT or wide excision with radiotherapy in patients with DCIS. Now, DCIS is an extremely heterogeneous group of disease. You have one set which is extremely indolent, may not progress to invasive disease. You've got low-risk DCIS being evaluated for active surveillance versus standard treatment with the ongoing trials. And then you've got a certain group of DCIS that may potentially progress to invasive disease. So we've always had multiple treatments in our armamentarium for DCIS, from surgery plus radiation and hormone therapy. Radiation from the standard older studies told us that it reduced the risk of ipsilateral invasive disease and ipsilateral DCIS. So how do we normally decide who needs RT? We've used the USC Van Prognostic Index. We've even had some studies validate the Oncotype DX recurrence score for DCIS. And we've had newer data from the UK ANZ study, which told us that HER2 was also predictive of radiotherapy benefit. But this group then decided to look at an additional score, which was the decision RT and its response to a biosignature, evaluating what patients actually needed radiation versus not. 485 patients using this biosignature on FFP blocks gave us an understanding of what group was going to do well and was not going to do well, and whether the known clinical pathological features, including HER2, which was a newer predictor of radiotherapy, was representative of that risk. Unfortunately, the multivariate analysis suggested that these traditional features were not associated with IBTR and did not predict for it. So this novel biological subtype actually was more helpful in identifying patients who had an unacceptably high 10-year recurrence or those who could potentially avoid RT also. So I think this needs to be taken in a larger randomized setting to be proven more effectively or validated by bigger groups. So we can probably use this further in our analysis. The next, of course, was something which I think has a little bit of controversy associated with it. It talked about low-dose tamoxifen for reduction in mammographic density. And I think here the concern is that we've always suggested tamoxifen has a definitive benefit for reduction of risk in women, both in the adjuvant setting as well as in the prophylactic setting. Unfortunately, there is a compliance issue. Even in the adjuvant setting, we know that the compliance drops to 50%. And what they suggested is that if you reduce the dose of tamoxifen, you reduce the vasomotor side effects, and you may be able to improve compliance to the use of tamoxifen. So this was a large double-blind 6-arm randomized study, the Charisma phase 2 trial, where 1,400 women were accrued, 566 premenopausal, 800 odd postmenopausal, suggesting that from various doses of 0, 1, 2.5, 5, 10 milligram, and 20 milligram of tamoxifen was given to understand a reduction or an percentage reduction compared to 20 milligrams, which is standard dosing of tamoxifen, in density of the breast on mammography. So there was a non-inferiority reduction in a group of premenopausal women from the standard density using 20 milligrams of tamoxifen. This, however, did suggest that you are able to reduce density on mammography. We know that density is also a high-risk feature. We know that it's also acting in a certain way. But whether this 2.5 milligrams of tamoxifen reduces the risk of breast cancer also, I think is something that we'll only see when larger studies evaluate exactly that question, because this is just a surrogate for response to tamoxifen by density. Now, the last two abstracts are actually about artificial intelligence and deep learning. And this one used a meta-analysis to understand what is the use of artificial intelligence for screening programs. We've seen a burst of studies that talked about the use of artificial intelligence and comparing it to a radiologist, both single as well as double radiologists in mammographic screening. So this meta-analysis put together 12 studies and looked at how many of them were included. When they talked about types of AI systems, 94% of the studies were less accurate than a single radiologist. And all the studies were less accurate than the consensus of 2 radiologists. They very conveniently concluded that it does not allow for judgment on AI, but I think it's safe to say that for now, the radiologist's job is pretty safe, because there's enough evidence to tell you that the radiologist, especially when there is consensus of 2 or more radiologists, is currently still better. Now, I'm not going to get into the controversy on mammographic screening itself. I think that's a debate for another day. But what we do know is that the AI systems are not sufficiently specific enough to replace radiologist double screening in screening programs. The last of the abstracts is prediction of distant relapse using H&E samples or slides with patients with breast cancer, and using a deep learning model to predict this relapse in these patients. Now, this is really exciting work, because not only is this giving you a predictive model, this is something that's fairly replicative. All it needs is a single system and unit in place, which is a digital microscope, and evaluating that with it. So this deep learning model was developed to predict the risk of recurrence in 5 years. What they used was H&E slides from that patient's tumor and did a pre-processing and risk prediction step. When they added in the clinico-pathological features, they improved the area under curve to 0.81, which is substantially increased. What's interesting to understand is that deep learning applied to a whole slide imaging predicts the risk of relapse in early HR-positive negative breast cancers most effectively. And what this is promising to do is therefore develop a tool allowing for treatment decisions at a fairly low cost. And this is going to be a great challenge against the currently available expensive tools that we have of gene profiling, where we are then offering our patients chemotherapy and or not, depending on various recurrence scores. So this is hoping to aim to be a low-cost technology, blocks with deep learning in a much more effective manner. But again, still food for thought, needs a lot more validation and larger studies, and I think is going to be the way the future is moving. Thank you.